Hello, everybody, and welcome to the OrthoNinja Academy again. We've been talking about trauma for the last month, and just for a change of flavour, we're going to be talking about foot and ankle problems for the next month. My name is Amer Shoaib. I'm a consultant in Manchester in the United Kingdom, and I'm joined by my colleague and friend Raheel Shariff, who's a consultant in the Kingdom of Saudi Arabia.
Amer, nice to have you.
Great. And the way that we're going to go through this session is by going through some clinical cases, as we've done before, and throwing out some polls for you to answer. And it's really important that you interact by answering the polls. Remember that we don't know who's given whatever answer, and so there's no embarrassment factor. Just say what you think, and hopefully we'll be able to get something useful out of it. And I think it'll be really interesting to see, just to gauge people's opinions. So Raheel, we're going to start by going through a case. That's the com on the Starship Enterprise. And we're going to move on to case number 1. Right. Okay, so, whoops. Right, so we've got a patient who's a golfer. He's 58 years old, and he's got a long history of chronic ankle pain. He hasn't had any specific injury that he can remember, and he hasn't had any prior treatment. So as far as he's concerned, it's just a grumbling ankle pain, but for some reason his symptoms are getting worse. He's still able to manage to play golf, but he's just got this grumbling ankle pain. So let's move on to the next slide. And you've seen the x-rays. Having seen those x-rays, we're going to ask you, what imaging would you want next? What imaging is going to be important for the management of this patient? So we'll let you make your decisions, and then I'm going to ask Raheel to go through the different options, first of all by looking at the plain x-rays, and then deciding what investigations might be helpful for the further management of this patient.
Thanks, Amer. So we're looking at this patient's x-rays, and what we see is there is some hint of a cyst on that bottom image on the right in the talar body, possibly moving into the neck. And we're not quite sure, so we've got options of CT, MR, CT and MRI, or SPECT CT and MR. Now, we want the bony lesion sorted out, so a CT is going to help us there. And the MRI might come into its own because, remember, a lot of these patients have ligamentous instability. And if you're looking to do a good reconstruction of this patient's problem, you want to sort out the ligaments as well. So I would go with CT and MRI to look at the soft tissues as well as the bony lesion here. 50% of our audience seems to go with that. So this case is just a flavor of things to come. We'll deep dive into this case later on as well during the talk to see how we deal with this.
Okay, so most of the audience and Raheel have gone for CT and MRI. Okay, so there's his CT scan. So quite a surprising result on CT scan, and a little bit scary, if I'm honest. So Raheel, could you tell us what you think? And let's go to another question. And the poll is going to be this time, what are we going to offer this patient?
Okay, so if this patient walks into my clinic, Amer, I'm going to be thinking, how do I turf him over to you? So this is a tricky one. So this patient is a 58-year-old and he wants to keep his ankle mobile. Now our options are, realistically, we've always got to offer him an ankle fusion because that's a tried and tested formula. It works, but that's not the theme of this talk. The theme of this talk is how do we manage these defects. You've got structural autograft, which is an option. And for those of us who aren't familiar with structural autografts, it's basically taking tricortical or fairly robust grafts, not cancellous bone, but robust graft, and press fitting it into this defect. And by way of just providing some structural integrity, the pain tends to disappear. We're not worried too much about the cartilage in this instance when we're considering structural autografts. Allograft depends on which neck of the woods you are in. If it's easily available, you can use it. AMIC with bone grafting and ankle replacements. So all these are viable options. Would you consider an ankle replacement, Amer, in this patient?
You know, I'd be very loath because I think it's going to be a big ask for an ankle replacement. You're going to have to fill that gap to support the Talar component, and
but
I'd be worried.
What about if this patient said, "I want to keep my movement"?
Then I think that's an option you've got to entertain. Okay. If you can't convince the patient otherwise, then they need to understand the risks. But I think there's always an option for doing that.
Yeah. Okay, so these are our options, and the audience seems to be fairly scattered with regards where they're going to go. Majority seem to be tending towards a structural autograft, which is a fairly reasonable option here. AMIC with bone grafting, where we use autologous matrix-induced chondrogenesis with bone grafting, is a reasonable option, but as we go into the talk further, we'll discuss which patients benefit from this particular intervention. Over to you, Amer.
Okay, so he wants to keep his joint. He wants to maintain his mobility so that he can carry on playing his sport. So you're offering him a joint salvage with structural bone graft. So it's quite a large size defect. How are you going to get to that area in order to graft him? So you've got the option of going from the front, or you could go through a medial malleolar osteotomy, or an option is to take off the posterior malleolus. So it's quite interesting to see what people have decided so far. So not everybody's answered. So
the thought process here has to be which is the easiest way to approach this. And in the ankle, you can pretty much go 360 degrees all around the ankle. Transfibular approach laterally, transligamentous approach, which I think Jeet and Lyndon have described. There is, this was new to me, there is the anterior approach, which you can use, or the medial malleolar osteotomy. Now, the box standard workhorse of central and centromedial lesions tends to be the medial malleolar osteotomy, which most of us are comfortable with. And we will discuss how to do this, some tips and tricks with regards to this, and discuss further how this case was dealt with in the talk. Which way would you go with this one, Amer?
Well, as with a lot of questions, there's no one right answer. I think because the lesion is more on the medial side, and it does extend quite posteriorly, I think I'd probably go for a medial mal osteotomy.
Fair play. I think that's
what about you?
Well, so a medial malleolar osteotomy is completely an obvious answer. I tried doing things slightly different, and during the course of the talk, I'll show you what we did with this particular case. Okay, is that the end of that first case? This is just to give us a flavor as to where we are at as a group. What is our thought process? And the majority seem to be wanting to head towards a medial malleolar osteotomy, which is perfectly reasonable.
Yeah. So Raheel's now going to give us a talk he's going to drag me into the 21st century by bringing me up to date. So take it away, Raheel.
Thanks, so lots of outcomes we're going to be discussing through the course of this talk. And one of my outcomes is to actually get Amer to start using some of the more recent technology. No offense, Amer. Okay, so with regards to Talar defects, we all know what to do with this lesion. Okay, so this is a fairly straightforward microfracture. Every one of us knows how to do this. But there's a whole spectrum of problems which we come across. The case in point which we were just discussing, and that area in between the HEPL 2s to 4s, and this is obviously HEPL 5. So the problem is, I'm going to push a poll to all of you now, okay? Because let's get into some controversy right at the outset. When it comes to microfracturing, would you consider biologics, i.e. stem cells, PRP, hyaluronic acid, what have you? So your options are absolutely every time. No, because that you'd rather just dance around with some pixie dust, and not sure. So where are we with Amer? when you microfracture,
looks like the audience are with you on this one, Raheel, because
the majority seem to be on the fence. They're not entirely sure, which is perfectly fine, because the evidence doesn't seem to lean one way or the other. Amer, what would you do?
Well, I think it's when I consider microfracture to be a biological process in itself, because you're stimulating the formation of new tissues by performing the microfracture. And whether that needs to be supplemented or not, to be honest, I'm not sure. Okay. Because there are good results already with microfracture, and we don't know if there's any evidence that PRP or the addition of stem cells really adds very much. So to be honest, I'm on the fence with this one.
Fair point, which is what the majority of the audience seems to think as well. No one's entirely quite sure. We will look into what the evidence seems to suggest regards this. Now, here's another slightly technical question, because we all microfracture. We do it day in and day out. At what point do you say, hang on a second, this lesion intraoperatively is not worth microfracturing? I'm just sort of, I'm just satisfying my cravings here. We've got to stop. At what depth do you stop and say this patient needs a bone graft? Is it 3 millimeters, 5 millimeters, or 7 millimeters? And there is evidence to suggest one way or the other with these. Amer, your thoughts?
Well, 3 millimeters, I'd feel perfectly comfortable with microfracturing, and 7 millimeters, that's quite a deep cleft, and I'd be worried that if I microfracture, I'm just going to leave them. There's still going to be some cysts left behind, and 5 millimeters, it seems that it's achievable. What about you?
So the majority of the audience seems to go with 5 millimeters. They're not comfortable microfracturing beyond depth of 5 millimeters. I go with the majority there, because evidence seems to suggest that there's only so much that microfracture and that clot can do. And we're asking too much if we're going beyond 5 millimeters. So 5 millimeters is the right answer in this case. And we look at where the evidence for this comes into play. Okay, so what are the issues we're going to be dealing with regards to OLTs? The problem is we don't actually understand the history entirely, because a lot of our knowledge, working knowledge, even right now, comes from the knee literature. There's a lot of work done with the ICRS with regards to cartilage regeneration, but a lot of this has been based on what the knee chaps have been doing. There is no gold standard to treatment, because as we can see, there's a whole host of treatment options, and there is actually no easy answer for the massive defect. To compound matters, we don't know when to intervene, because in the ankle, we do tend to have these kinds of this is a patient who was completely asymptomatic with this MRI. So do we actually intervene as a precaution to prevent problems, or do we wait for those problems to set in? Because we do know the ankle is slightly different to the knee, because in the ankle, the disease presents itself fairly in a terminal stage when we've got these massive cysts. So the patients have been sort of plodding along, quite happy, and then when we scan them, they've got this massive defect. So when do we actually intervene? And finally, there's no actual simple answer to this edge lesion, because these are uncontained defects. You microfracture those, or you put an AMIC on them, there's a problem that might just slope and fall off. So we don't really have very good answers to these questions. Do we use allograft? Do we use structural autograft? And the ease of availability of allograft if we decide to use allograft. So what are we going to look at in this talk? We're going to go through the nuts and bolts of OLTs, just a bit of background on that. How do we diagnose these lesions? And the important crux of the matter, how do we treat them based on the most recent evidence? Monroe is the chap who basically coined the term osteochondral lesions. He was the one who picked it up in the first instance in the 17th century. And he described with regards to trauma. And actually, back then, he got it right, because this paper from Saxena et al. Looked at athletes who've had talar injuries, and they found 50% of sprains, ankle sprains, do have an underlying cartilage lesion. This paper by Beat Hinterman in the British JBJS looked at ankle fractures. So Beat scopes all his ankle fractures, and 73% of ankle fractures have an osteochondral lesion. So it's vitally important to actually scope ankles, even if in a box standard setting, whether you dry scope or wet scope, that's your decision, but it's important to pick up these lesions and possibly deal with them with chondroplasty or microfracturing them to prevent these injuries from grumbling on and causing pain. This is why some of the outcomes seem to be pretty poor with ankle fractures. Amer, do you tend to scope all your ankles?
No, if I'm doing an ankle fracture, I really don't. And it's a completely blind procedure for me. So it's all indirect reduction, and I don't tend to look into the ankle joint at all. I don't think that's a regular practice really in the UK. Is that something you do?
I've actually changed practice and I've started scoping all my ankles now, yes. We do use arthroscopic assisted ankle fracture fixation. I know you're a proponent of that when you're trying to sort of make sure your cartilage, your plafond is lining up nicely. But I've changed practice and started scoping all my ankles, and it's surprising how many of them you find lesions in. Biat's a huge proponent of this, school of thought. And finally, Richard Ferkel showed that 95% of patients who are undergoing a Brostrom Gould repair tend to have osteochondral lesions. Now, in my practice, I've not found such a large number because I routinely scope all my ligaments before repairing them. But there is a significant amount of patients who will have OLTs, which we may miss, and this might cause ongoing issues. So what's the pathophysiology? We know there's cartilage damage due to trauma. Subsequently, what tends to happen is you've got your subchondral bone, which is exposed, and that gives rise to an increased hydrostatic pressure from the joint. Joint fluid starts sort of ingressing into that defect and giving rise to your typical sclerosis, osteolysis, and eventually the large defects. So Wodika et al., this is a paper in the FAI in 2016. Basically, he proved what we all are reasonably aware of. Anterolateral lesions tend to account for the vast majority of acute trauma. Okay, they seem to be more shallow, saucer-shaped lesions, but the posteromedial lesions are usually due to ongoing instability and impaction of that medial talar dome into the tibial plafond. And they tend to be much more deeper lesions. Now, this was a great paper by Elias et al., who mapped out this topography of the dome of the talus, and they divided them into 9 quadrants and found that majority of the lesions tend to occur in the medial quadrant and the centromedial quadrant. And the largest diameter, AP diameter of lesions tends to be posteromedial. The mean transverse diameter is anteromedial, and the depth, the lesions with the which are having the most depth seem to be central. So predominantly, the problems we will get with these defects are the centromedial lesions because they are the ones which are longest, widest, and deepest. How do we diagnose? It's quite frustrating because there's no clear-cut picture. We've got to have a high index of suspicion for the patients who've had trauma because majority of them tend to have pain with activity and have a previous injury. Examination is fairly non-specific, and one nice tip is when we are examining these patients, we plantarflex the entire ankle and start probing the joint because then you're uncovering that dome of the talus and you start feeling if the patient has pain. Pain behind the medial malleolus is fairly pathognomic of a posteromedial osteochondral lesion, but in general, OCDs, as we know, have fairly diffuse, non-specific pain patterns. Quick word on the classification. So there's the Burnt and Hardy classification, but Heppel's MRI classification is what we tend to use most widely. Stage A is just a cartilage injury or a chondral injury. It's actually not very well visualized on an MRI if we don't know how to read it properly. CT arthrograms tend to give us a much better idea of stage 1 injuries. Stage 2 is a flap fracture. So basically you've got a cartilaginous lesion and it's gone through into the subchondral bone and created a bit of a flap, as you can see there. And there's a bit of bone marrow edema in 2As because that's an acute injury. In 2Bs, you've got chronic non-edematous bony patterns. And that's 2B. 3s, you've got a completely detached lesion with a rim of fluid under the lesion, but the lesion itself hasn't displaced. And as you can see in this stage 4, this lesion is completely flipped 180 degrees. So the cartilaginous surface is facing the subchondral saucer. And the 5s are the big cystic subchondral lesions. So what's our goal of treatment? Essentially, what we want to do is we want to create a cartilage repair, which is as close in characteristics to hyaline properties, mechanically, biologically, and histologically. The problem, though, is that the cartilage or the tissue that we generate is completely different to what we would like. We just don't have the technology. And the other problem compounding, as I've alluded to, is that a lot of our evidence seems to be based on the literature from the knees. And as we know, the thickness of cartilage in the knees is much more than in the talus. And the talus, to compound matters, is quite a dome shape with lots of slopes and irregularities. So even if we create a tissue which is reasonable, mechanically, it's really hard to sort of create that congruent surface. Our surgical approach is determined by essentially the kind of lesion, where it is in the talar dome, what's the size, and what's the depth of this lesion. What's the patient's profile like? Is this a young patient? Will they be able to regenerate well? Or it's an elderly patient in whom we're really trying to push that envelope? Have they had previous treatments? So if you've had a patient who's had microfractures done, would you go back and microfracture again? Now, this is a question I posed to Amer. Amer, let's say you've had a patient who's had a microfracture for a fairly box standard osteochondral lesion in the medial dome of the talus. The patient's having ongoing pain. At what point do you say, my treatment has failed, and at what point do you decide to intervene?
Well, I think with a microfracture, there's good evidence that you can give it time.
Yes.
So I would say I would give it at least a year. And there's even one paper that says that even at 18 months, there are improvements in symptoms in patients. So I think it's something that you need to give time to. If I'm one of those people that thinks that if you try plan A and it doesn't work, then it's probably not worth trying plan A again. So I that's the point when I'd probably think, well, maybe I need to do something slightly different. But there is an approach to perform a microfracture again, and some patients that works for. Unfortunately, it's one of those. This is one of those areas where there isn't a vast amount in the literature, and so it's not absolutely clear as to what the right direction to go is.
So you're absolutely right with regards the fact that patients who have had a microfracture can take actually the duration quoted is 2 years. So you actually pre-op counsel your patients saying, this is not like a hip replacement. You're not going to get up and get going immediately. It may take you anywhere between 9 months to 2 years to get the maximum benefit. And this is based on a paper by Kim et al., who have looked at long-term results of microfracture, and they found that patients continue to improve over time up to a maximum of 2 years. So you're right, give them time. And the evidence seems to suggest regards re-microfracture that if you have done the microfracture and you're comfortable and confident that you have gone down to that subchondral bone and made it bleed, and in spite of that, let's say 18 months down the line, the patient is still having problems, there's no point going back and re-microfracturing. Now, the problem is some of these patients come to us from elsewhere, and we're not entirely sure if the job done has been reasonable. Then it boils down to whether you know the surgeon and you're confident that they've done it in the ideal way, or you go back and re-microfracture. So that's what the evidence seems to suggest. Now, when I keep saying evidence, we're going to push a paper to you in a moment, which is a consensus statement from the International Ankle Cartilage Society, where they've had experts who have looked at all this and come up with these suggestions. So what are our surgical options? We've got a whole host of toys to play with. Okay, we've got microfracture. We've got microfracture with biologics, stem cells, PRP, and we're going to discuss what the evidence for this is. We've got autologous matrix-induced chondral genesis, where we essentially microfracture, and if it's a fairly large, substantial lesion, you can take a cartilage scaffold, infuse it with stem cells, BMAC, and place it on that lesion to essentially get them to heal. Osteochondral autologous transfer system, where you take cones of bone and the overlying cartilage from non-weight-bearing areas and plug it in. Allograft reconstruction, but you've got to have fresh allograft. This is not your box standard frozen dried allograft. You've got to get fresh allograft, and the way this is done is you CT scan the opposite talus or the same side talus, map out the measurements and send it to a bone bank, and when they have a fresh cadaver which is HLA cross matched and typed, they will find the right matching talus and send it across to you. It's quite tricky. This is fairly commonplace in the US, but in the UK and elsewhere, this can be quite a challenge. Juvenile particulated cartilage. This is something which Lucian has used quite a lot and published on, where we take under 16-year-olds cartilage, It's particulated and it's been cleaned out, and you basically layer it on as a layer. The difference between chondroplasty and microfracture. Chondroplasty is essentially just shaving the irregular cartilage rather than creating those microfractures with the awl. And this is typically used in professional athletes who are in season, and you don't want to cause a microfracture and get them out of play. So you get this done during season, and once they're done, you reassess the damage and then go ahead and do what's needed to be done. This is quite common in the professional sporting world. But at the end of the day, it all boils down to what's available, the cost, and the preference of each individual surgeon. What skill sets do you have in your toolbox which you can employ for these? So let's look at what the treatment algorithm is. Some of this is stuff I'm familiar with, but some of this is stuff which is based on the evidence and a combination of the two. Your first question you're going to ask yourself is this a contained defect or an uncontained defect? Now, for a contained defect, your options are microfracture or AMIC. And now whether you use biologics and bone graft depends on whether you are a proponent of biologics or if you have a cyst. So if you've got a cyst, there's no point microfracturing. You've just got to pack it with bone graft. So because microfracture is such a daily bread and butter with all of us, we're going to just deep dive into the evidence and how we should be doing this. We know it's indicated for full thickness chondral or osteochondral lesions. Now, this is a paper by Lambers et al., and Amer is going to push this to you. It's worth having a read. This is a paper which has the longest follow-up in athletes who have had microfracture, because essentially high demand activity levels. And they have found that 78% success rates at a mean of 6.5 years follow-up with athletes. They've over 90% returned to sport, and 53% went back to sport at a pre-injury level. So they do seem to work, and microfracture does work. Now, Woo-Shin Lee from South Korea, he's a big name when it comes to cartilage regeneration in the foot and ankle world, and he's done a phenomenal amount of work. I think he's got the longest series. I'm sorry, I don't have that paper, but he has shown 200 patients who have had microfracture followed up for 11 years with an 80% success rate. That seems pretty phenomenal, and a 10% revision rate. But they do tend to do things slightly different there. We'll touch upon that later in the talk. This is a systematic review from Nick Van Dyke's group, which again states that there's an 85% success rate. This is what we quote to our patients with microfracture. And the question now I'm going to pose to all of us is, who do we microfracture? Do we microfracture patients who have a lesion which has got a diameter of less than 15 millimeters or less than 10 millimeters? So Amer, what's traditional saying there?
Well, I think traditionally, we go for something as big as 15 millimeters, okay, and hope for the best.
So you're absolutely right. That's what we've all been brought up with. But more and more evidence is coming out that 15 millimeters, the diameter of lesion with 15 millimeters is asking too much. So the consensus seems to be to start to do microfracture up to 10 millimeter diameter and start looking at alternative options beyond that, which isn't to say that that's what we all do, but this is what the evidence seems to be pointing towards. Now, this paper, I think, Amer, you've pushed this already. This is a consensus statement. Because the literature is so wide and varied, and it's difficult to come up with concrete evidence-based guidelines. In 2017, the FAI published this paper. This was 75 experts in the world of foot and ankle, particularly with regards to cartilage regeneration, who came together, trawled through the literature, and they were posed 14 questions on microfracture, bone marrow stimulation, and biologics. And they said that less than 10 millimeters, there's strong consensus that we should be microfracturing up until a size of 10 millimeters. What's the technique? We don't use, whether you use an awl or whether you use a drill or K-wires, it's preferable not to go beyond 2 millimeter diameter, the thickness of your instrument. And each of the lesions or the holes you create should be 3 to 5 millimeters apart. And these are all the statements which came up with strong consensus amongst this body of people. And how deep do you create a microfracture? Well, essentially as deep as it needs to get to create bleeding healthy bone. Intraoperatively, if we find we're going beyond 5 millimeters, then we should really consider bone grafting. This is what the consensus statement seems to suggest. Here is another question. Would adding stem cells or PRP improve our outcomes? So let's see what the audience says. 100% not sure with this. Okay. Amer, I know you don't use stem cells.
No.
Okay.
So would it improve outcomes? Again, on the basis that, when we perform microfracture, essentially we're trying to stimulate a biological response. So that's my basis for not using biologics. Okay. But the evidence either way still is very vague, and I'm open to persuasion.
Okay, great.
But I'd have to see the evidence first.
Sure. So majority, over 93% of our audience seems to not be entirely sure which way to go with this one. Okay, and I've put that question down, and the answers fairly categoric. You agree or you disagree, to see if we'll fall on one side of the fence. So microfracture with biologics, with stem cells, with PRP, with hyaluronic acid. What does the consensus come across? Essentially, amongst all the questions asked of this body and the literature they looked at, this was the only question which had 100% consensus for addition of biologics. Okay, so this is interesting. Now, PRP is debatable because the evidence, there's a paper by Gromelli et al. For those of you who are interested, please post on the chat and I'll email those papers across to you, which was a randomized controlled trial looking at patients who had microfracture with a single injection of PRP at the time of microfracture in one arm. Then they had patients who had microfracture with hyaluronic acid in one arm and microfracture with saline used as a placebo. So they had 3 arms to the study. And they found that the AOFAS and the VAS scores increased with PRP. But there are other studies which have actually said that PRP doesn't seem to work. However, when it comes to stem cells, there is a reasonable amount of evidence, particularly from Kim et al., who's done a lot of work with not bone marrow aspirate concentrate, but with stromal fat stem cells, things like lipogems, because we do know that fat-derived stem cells seem to have a higher concentration and better quality than bone marrow aspirate concentrate. So they've done a lot of work with fat-derived stem cells and found this significantly improved outcomes with giving these. Now, the question is, why is this happening? Let's go back to why we microfracture. We microfracture to create bleeding, healthy subchondral bone. We're releasing that bone marrow fat globules because we want to create a clot, and that clot converts into fibrous tissue. How does stem cells add to this? Stem cells basically help to stimulate that process, and you're adding additional growth factors, which might help to essentially get further acceleration to this process. There is a lot of basic science papers which have looked into this. When it comes down to the nitty-gritty, the evidence on this seems to be that some form of biologic is better than no biologic at all. Now, this is controversial, I take it, but this is coming from experts in the world of cartilage regeneration when it comes to foot and ankle, with big names there. And they had 100% consensus regards this. Stem cells, as I said, fat stem cells, there's a prospective cohort study. PRP, there was an RCT, but it was poorly powered. And we discussed this. We consider bone grafting if your lesion is more than 5 millimeters in depth, or there is an osteochondral cyst under the OCD. Here is a paper by Saxena et al., okay, which looked at, should we be actually considering bone graft? Are we going into a bit of an overkill here with bone grafting? So they had a prospective study which looked at 20 patients who had, so it was HEPL 2 to 5 lesions, 20 were bone grafted and 25 were microfractured. And these were all athletes or sporting individuals who were going back into sport. They found that return to activity back to sport was 4 months in the microfracture group, and return to activity was 5 months in the bone grafted group. So you take a little longer to get back to your pre-surgery levels and pre-injury levels with your bone grafted group, which tends to make sense. 96% good outcomes at 2-year follow-up with this paper. Now there's a trend with chitosans, you know, these glycerol phosphate and Cargel and all these commercial names. Do you have any experience with this, Amer? Do you tend to have you ever used these?
I don't use chitosan, but as you know, chitosan is a hemostatic agent,
Yes.
and
It does
we use it in pre-hospital care for
trauma.
bleeding injuries to stop people from bleeding.
Yeah.
So yeah, I've used chitosans, but not in this context.
So actually, there doesn't seem to be any evidence to back this. Whether you just do microfracture or you add chitosans. So I think using these is a bit of a waste of time and money. Just a quick shout out to the audience. If you do have any burning questions, please do post to the chat. Amer will be picking them up and we'll be discussing them as we go along. So just a quick synopsis on microfracture. Microfracture with a biologic tends to make sense. At least that's what the consensus statement and a lot of literature seems to suggest. Kim et al. Has done a lot of work with regards to this, and so has Wushin Lee. If you're microfracturing, don't use a drill which is beyond 2 millimeters in diameter. The finer the size, the more better the regenerate. And you don't want to go beyond a depth of 5 millimeters. You've got to seriously consider bone grafting if you're doing so. So which brings us to AMIC, which is our next option available in our toolkit. What are the indications? If you've got a lesion which is more than 1 centimeter, cysts goes without saying. There's no point microfracturing because you're really asking the body too much. And you've got to think of the age. You don't want to be doing this in someone who's very elderly. We've got a Manal has said low speed drill. Absolutely, Manal, that's a very valid point with regards in your microfracture. Thanks. So let's. I know there's a lot of confusion regards AMIC and MACI and MAST and all sorts. So what is AMIC? When it boils down to this, your steps are: you debride the defect, you microfracture it to make that base bleed, you pack it with bone graft, and then you put a cartilage scaffold on top. Now this is a commercially available cartilage scaffold, and I tend to use the aluminum foil from a scalpel's cover to actually place on the lesion, mark it out, and then cut it out to get a template, and then cut the cartilage scaffold out with that template. And then you pack it with pack that bone graft, put some stem cells in. I tend to use stem cells quite generously in my microfractures as well as in my AMICs. Now I do appreciate I'm in not currently in the NHS, and there can be cost issues with regards to the use of stem cells. And that's how it looks at the end of the result. Now, the quick point on how you anchor this cartilage scaffold onto your bone grafted cyst. A lot of us are asked to use fibrinogen or glue to sort of attach it around the edges. The ICRS Society has actually done some work, and they have shown that using glue can actually cause resorption of that edge between the healthy cartilage, between patient's cartilage and this cartilage scaffold. It causes a resorption and creates a layer there of a gap through which you can again have fluid going in and creating a cyst. So in my practice, I tend to use the PRP clot triple spun, so you can get the fibrin. It's quite clotty and sticky, and you can use that as your glue, and that doesn't cause resorption. This is something which the Italians have been proponents of, and they've published regards.
Raheel, when you put it in, just as a technical tip,
Sure.
It does swell up when it gets wet. So how do you go about sizing it?
So that's a great point. I tend to actually let it overswell a little. Okay. So there are some people who bone graft and go just under the surface of the cartilage, so they don't bone graft flush and then place their cartilage scaffold on top because they don't want that layer to swell up. I've done a fair few of these. I've done about 20 odd of these. I've not had problems in which the patients have complained of any mechanical symptoms with the swelling. Now it depends on what you use, because Chondral doesn't, and there's Chondral and there's Hyalofast and all the different commercial makes. You find out Chondral is a much thicker one, so you've got to sort of undercook your bone grafting to place it flush if you wish. Yeah. So here's the big question: does AMIC work? Okay, so again, Victor Valderrabano in Switzerland has published this. This is not a big study. It's 15 cases. It's 1 year follow-up, but they did show AOFS improved 63 pre-op to 86 post-op. However, this is a bigger study from Walter et al. They had 42 cases at 1 year follow-up, and they also showed significantly improved outcomes. AMIC does tend to work because you've got to ask yourself, what's the alternate option? A patient with this contained defect and a cyst. They're young. They want to keep their ankle moving. What are you going to do? Are you going to give them a fusion? You want to try to sort of essentially keep them ticking along, keep them moving, and patients do tend to do fairly well following this. So Amer is going to push to you another consensus statement. The previous one was on microfracture. This one is on scaffold-based therapies, AMIC. Okay, so this is, again, the group was asked a whole set of questions on does AMIC work? Now, some of the questions posed were, can bone marrow aspirate concentrate be added to scaffolds? The answer, strong consensus, was yes. Can they be used in uncontained defects? Now, this is interesting because you want to have a contained defect which you can pack with bone graft and cover with the cartilage membrane. The consensus seemed to be that yes, you can, particularly in those shoulder lesions which aren't too deep. They're, you know, almost the sloping shoulder lesions where you can just put a membrane on it just to help. What is the indication for AMIC? Lesion size more than 1 centimeter. So it's not 1.5 centimeters as we've all been brought up with. It's actually 1 centimeter. The indications have expanded. So it's a smaller lesion, a lower threshold to AMIC these days. So here is an example. I'm going to hand over to Amer to discuss a case. And then we're going to, once we've had a look at this case, we're going to go through the procedure steps on how to actually perform an AMIC. Amer, over to you. You want to?
Okay, so what we're going to do in this case is look at the radiology and go through the case history. And then I'm going to ask Raheel to tell us what his thought processes are and how he's going to go about managing this patient. So this is a 42-year-old lady, and she's had a microfracture, but it hasn't worked. So we're going to assume that she's been waiting for more than 18 months, and she's still got pain, and obviously she wants to be more active. She's still quite young. The radiology, what do you see on the radiology that sort of interest, Raheel?
So straight away, you're looking at what kind of Hepel lesion this is. Okay, this is a stage 5. Now you've got a cyst there. So automatically it becomes a stage 5 lesion. You've got some bone marrow edema around that cyst, which is good news. That means this is not, there's still some potential to regenerate. It's not sort of dulled itself and switched off the light. This patient is one of my patients. She had actually had a microfracture done by a hand surgeon and referred to me with ongoing pain. Okay, so the question you've got to ask yourself is, are you going to re-microfracture again? Now, based on the consensus statement we've discussed, if you're confident that the microfracture was done well, or if you have done it and the patient still has pain, then you shouldn't be microfracturing. Now, this was done by a hand surgeon. I'm not entirely sure this was done, well, possibly he doesn't do them as many of them as we tend to do. So I would have some skepticism about the nature of the microfracture done. However, the problem now is this patient has a cyst. So there is no two ways about going back and microfracturing again, because you're asking too much for that cyst to fill up and create fibrous tissue. So in my hands, I would be looking at a procedure which is going to fill that cyst. The question in my mind now is this a contained defect? The answer is yes, because you can see on that axial cut, there is a shoulder, a bony shoulder around that medial talar dome. So an AMIC in my hands would be what I would be considering, Amer.
Okay, so now this is quite a difficult question, but you've alluded already that these patients tend not to have one injury in isolation. You've got several different injuries going on. So obviously there might have been an ankle fracture, an ankle sprain, so they might have had a ligament injury, and there might be other complications following that. So which of these pathologies are going to concern you the most, and what order are you going to be aiming to treat them?
Okay, so this essentially comes back to some of the papers we've looked at and some of the literature in the earlier part of the talk. Ferkel has shown that 93% of patients who are having a Brostrom Gould tend to have an OCD. A lot of these patients actually have latent instability. Now, you can argue that the instability has occurred because of lateral ligament complex stretching out or a tear, because the patient had pain and their ankle gave way, pain because of the lesion. Or you could say that the instability has contributed to the lesion. It's just chicken or the egg. But a lot of these patients tend to have ligament instability. So let's see what the audience seems to think. So the order of highest priority is pain due to the lesion, ligament instability, and peroneal tenosynovitis. Yes, I think that that's the right answer, because there are some who tend to repair the ligament 90% of the time with these lesions. So what about you, Amer? When you go and scope a patient, let's say a simple microfracture, do you always stress view them and then with the opposite side?
Absolutely. Absolutely. I always do stress views first of all before I do my arthroscopy. Yeah. But I, even if I've got positive stress views, I'm still going to go inside and look for a synchronous OCD at the same
Absolutely.
time.
90% of the patients I do an AMIC in tend to have a ligament repair at the same time. I tend to do it all arthroscopic. It works well. And even the ones I'm not entirely sure these are stable or unstable, I'd rather err on the side of caution, create stability there, because I don't want the repair we've created to have to be jeopardized by any latent instability that the patient might have post-op. Okay.
So next question is, what are you going to do next? So I'll push that question through. So what do you think we should do? So we've got the options here of having just a diagnostic injection.
So would you consider a diagnostic injection in this?
I think when we have a scan which already shows significant pathology, if you had any doubts about where the pain was coming from, I'm not sure that the injection would really help that much. So personally, I wouldn't think that an injection would really be of any additional value. Okay. Would you ever consider it?
No, I don't consider diagnostic injections when you've got an obvious lesion. So this was actually a trick question because we've not put AMIC into it. So I just want to see how much of the audience would respond. A lot of them are going with microfracture with BMAC. Fair play, you could consider, but always remember there's a cyst there and you're asking too much with just bone marrow aspirate concentrate and remicrofracture. I think we've discussed this, the chances of this lady needing a ligament repair. Yep.
All right, so let's see what people think. So you've got the option to vote now.
Great. So while our audience is voting, I'm going to go back to the talk and let's see what we did with this. Let's see what the steps are. So as we've alluded earlier, I always do stress views and arthroscopy prior to an AMIC, particularly if I'm considering an open AMIC. There are people who tend to do an all arthroscopic AMIC. They have the technical skills and they have the special instruments which they've devised, and it tends to work. I find it quite challenging. So as I said, the box standard workhorse for a central or a medial lesion is your medial malleolar osteotomy. Okay, and the question is, where do you make your osteotomy? Now, you tend to think you want to make your osteotomy right about there because you can access the lesion. Always remember, you want to go just a tad more medial into the tibial plafond because that's what really opens up and gives you access, okay? And when you've done your osteotomy with your saw blade, you can actually railroad it. We'll go through it in a small video after this. You want to crack your cartilage with an osteotome because your saw blade can actually take away about 3 millimeters, 4 millimeters of cartilage with the power saw. And when you're trying to fix that back, that causes a bit of a loss of congruity. So what we're going to do is have a quick look at this patient, a video on this patient's, let's see, we're sharing this video. So this is the approach. I put 2 K wires in to railroad the saw through. And as you can see on the right-hand side, we drill and put a screw in before. If you're not careful, as you can see with this X-ray, you can actually create 2 fracture fragments, which I did in that case. And then once you've opened it up, you can see this sort of gooey, sticky mucoid substance coming out of your cyst. Now, cysts look small on that MRI, but actually, surprisingly, it's quite large when you look at it. Once you've done that, you might create a healthy bleeding bed with your drill or your K-wire. You've got to use saline cooling. I did use it, but I've sort of cut down this shots to minimize and save time. Once you've done that, you want to pack your bone. And sometimes the bone is easily accessible and taken from your distal tibia, from where you've made your medial malleolar osteotomy. If you need small amounts of bone, you can pick up from there. As you can see in this video, I take a small chunk out of the medial malleolus. A laminar spread is a great way to distract and keep that osteotomy open. And one top tip, when you're wanting to get access, hold your heel and twist it into valgus. That really opens it up. And as you can see, I do stress views after doing ligament repair to make sure that I'm quite happy and comfortable that this patient's ankle is stable and it's not going to jeopardize our repair. Okay. Moving on with the talk. Sorry. There you go. So that's when it comes to contained defects. We've got microfracture and we've got the AMIC. More than 1 centimeter lesions, consider your AMIC, or a cyst, consider your AMIC. So what about your uncontained defects? Now, these are the interesting ones. So here's a case. We've got a patient. What can you see, Amer, on this scan?
Right. Well, quite worryingly, you know, we can see a very large level of a large amount of edema over on that lateral side, and it's crossing over the sort of the middle of the talus, and there's also some edema extending down to the subtalar joint as well.
So now the thought process going through your mind is this a contained or an uncontained defect?
Well, I'm a bit worried that it's not going to be contained.
You're absolutely right. This is not a contained defect. Further imaging shows that, because that lateral shoulder of the talus is completely involved. So what would you consider in this kind of case? You've got an uncontained defect now.
Well, uncontained, we can't use the sort of the AMIC type approach because we can't contain it because it's actually so massive. So we need to start thinking a little bit more laterally and perhaps think about bulk allografts in order to fill that space.
So let's ask our audience a question. So what are your options here? We'll give you a moment to answer that. You've got bone graft and AMIC. Now, the previous consensus statement said you could use AMIC in an uncontained defect, but I think you're really pushing the boundaries here. It's doomed to failure if you go down an AMIC route here. You've got an ankle fusion, and I think it's important to highlight that every patient who has procedures done, whether they joint salvage, I think it's important we offer them an ankle fusion and be quite unbiased. As surgeons, sometimes we want to do something, but that might not necessarily be the best thing for the patient. So do you always offer your patients the ankle fusion, Amer?
I think that it's wise to give them a whole range of options because all we can do is give them information and let them make an informed decision themselves, because at the end of the day, they know what demands they're going to require. And if they feel that their demands are low, they might want to go with the safer option. If they have got high demands, then they're probably more willing to consider other options, which may not give as great a result in the long term.
Absolutely. Injections, yeah, you can buy some time with injections, I guess. Phone a friend, turf the patient possibly, and that's not an unreasonable option. I say turf, but sometimes if you're not comfortable dealing with the case, it's probably wise to refer it on to a tertiary center where people have volumes and numbers where they have the experience to get it right first time.
And another option is to actually discuss the case, discuss it with colleagues, discuss it in an MDT, discuss it at sort of a bigger level. I quite frequently will send X-rays or scans to, some of my colleagues and say, well, even in other centres, and say, can you tell me what you would do with this? Because it just helps to inform, and get a better idea about if your plan is rational or not.
Okay, so our options are a structural allograft, if it's available, bearing in mind they don't do very well, and you've got to counsel your patients, or an autograft. Now, in this case, you get these fresh cadaveric allografts which have been irradiated. And what you tend to do in a technical tip, you can get an Elizar of circular frame 2 rings and pass your wires through the talus to hold it in space and then cut it out, because it's really hard holding it and cutting it out. You map it out and map the lesion out preoperatively on your scans and cut out that amount and then fix it. So you do, obviously this needed a fibular osteotomy. This was a case I did with Mark. Which brings us back to our initial case we discussed earlier, the 58-year-old golfer. Now, Amer suggested considering a medial malleolar osteotomy, which is a perfectly reasonable option. But because this was right at the central dome of the talus and more anterior on the scans, you could consider an anterior approach. And in these massive talar defects, you can take structural graft. Now, you can even take iliac crest wedges, fashion them, and then pack them in there, like 2 or 3 strips. You can sort of decrease the height to bring that as a dome, infuse it with stem cells, throw pretty much what you can at it. Now, it's really hard to sometimes size these in a 3D way. So you can use bone wax as a tip. You can pack it into that and then just lever it out with a McDonald or an osteotome and use that as your template guide to size your lesion, to size and make your cuts for your autograft or allograft. And that's fixed in there. And this is 10 weeks post-surgery, as you can see. And there is incorporation. Now, not everyone is going to be as fortunate as this patient. And it's really important to actually counsel your patients and tell them there's a 50% chance of not getting this right. And this is based on literature. Clifford Jeng and Mark Meyerson published their series, which is one of the bigger ones on these structural allografts, and they showed a 50% failure rate at 5 years. But you do have patients who are willing to sometimes take that risk. They're far and rare, but they will come and say, it's fine, I'll go with it. So these are not very often done as particularly allografts. I tend to use structural autograft, and a friend of mine, Emilio Wagner in Chile, is actually a great proponent of this, and he's taught me the technique where you can just take iliac crest, tricortical, and just press fit it into your defects or fix it into your shoulder with screws. And patients seem to be really happy. They seem to do well with this. This is a paper by Kim et al., which is about 60 patients, 30 odd patients, and they used structural autograft from the distal tibia because they were right there. They open up, just extend the incision a little more and get the core drill, create your, clean up your defect and take plugs of bone from the distal tibia and just pack it in there. They had 32 patients and they had significantly improved scores at 2 years final follow-up. Interestingly, 96% of their patients said that they would have this procedure again, and over 90% returned to work and play. So it's not all crazy stuff. Some of these do work if we base them on sound principles of a press fit mechanism. A quick word before we bring it all together and finish off on future perspectives, okay? So gene therapy is pretty big now. Woo Shin Lee, he's at Severance Memorial in South Korea. They're essentially eons, light years ahead of what we are doing in the West or in other parts of the world with regards cartilage regeneration. They're using tumor growth factor beta-1 and enhancing the chondrogenesis. We'll touch on that in a moment. MicroRNA 449A is a gene which, if you inhibit this gene, it reduces destruction of cartilage through interleukin-1s. And they are recruiting stem cells with interleukin-8s and MEP3 alpha. Now, this is an advanced phase 3 clinical trials, and we don't see any of this in our traditional literature. We tend to see this in tissue engineering journals and osteoarthritis and cartilage journals, more towards the borderline of basic science meets clinical practice. So Woo Shin Lee, this is his work. He is looking at genetically engineered allogenic human chondrocytes, which are expressing TGF-beta-1. And they are getting this gene and piggybacking it on retroviral vectors. So they're introducing it into retroviruses, and these are used as vectors and transducing chondrocytes into it. And they then tend to irradiate this to prevent malignant transformation and inject this a 1:3 ratio of the transduced chondrocytes versus normal chondrocytes, and they're finding that fairly good results. And this is actually now, I think, in press. But that's weird and fancy. It's something which will be years away before you and me can use. So let's try to bring this all together now and work on our treatment algorithm based on the evidence we've looked at. You've got an OLT. You've got to decide firstly, is this acute or chronic? Because we do know, and I apologize, I've not touched on this, the poor prognostic factors for treating an OLT are the size of the lesion, the presence of a cyst, and the duration of symptoms. So if you have symptoms beyond a year, you've probably got lesser chances of better outcomes. So this is an acute lesion. What do? We decide then, is this undisplaced? If it's undisplaced and it's an acute osteochondral injury, you can treat it in plaster and hope the patient gets better. If it's displaced, then you've got to decide what is the amount of bone under that cartilage. Is there a reasonable amount of bone under that cartilage for me to pin this and fix it? If it's adequate, we try primary fixation. And you can do this with your bioabsorbable screws or headless Herbert screws. If the amount of bone under the cartilage fragment is not adequate, and you think when you're going to go in and fix that, it's just going to shatter, then you've got to consider excising and removing that lesion, microfracturing it, and possibly adding orthobiologics. As I said, the evidence seems to, well, some of the evidence seems to back the use of orthobiologics, and you will not be criticized for using it because every little helps. That's with regards acute lesions. When it comes to chronic lesions, you want to look at whether this is a displaced lesion or an undisplaced lesion. If it's undisplaced, is your cartilage stable? So you do a scope, you probe. And is this lesion a cystic lesion? If it is cystic, you are going, and it's a stable defect, so you've probed, your cartilage is not sort of wobbly, it's sort of, there's a reasonably good, strong, nice layer of cartilage which isn't moving and jogging about. But there's a cyst underlying. You can do retrograde drilling, and you can pack it with bone graft as well. Now you have companies, without naming, but some of the big companies have very precise targeted jigs with cannulas in them, which you can place on that lesion, and through that actually make sure that you're targeting drilling right into that defect and pack it with bone graft through that flute. If it's there is no cyst, then you just do drilling without bone grafting. If your lesion is displaced or the cartilage is unstable when you probe it, then you've got to look at the size. And this is a slight modification. So this is a modification of Ferkel's paper, because it was an old paper which said 1.5 centimeters square, but Ferkel now has come out and said 1 centimeter is the magic number. So if your size is less than 1 centimeter diameter and your lesion is less than 5 millimeters in depth, you can microfracture and BMAC or stromal fat stem cells. But if your lesion is more than 5 millimeters in depth, you've got to seriously consider an AMIC type of procedure with some bone graft. However, if your lesion is more than 1 centimeter and it's cystic and contained, you can AMIC with bone graft, as we've discussed. If it's uncontained, you've got to consider your structural autografts. So hopefully that has been a whirlwind tour through the world of talar cartilage defects. In summary, we're going to finish off and then have one final case we're going to discuss before we end. You want to consider orthobiologics. There is no harm in using biologics with your microfracture. In fact, as we said, the consensus seems to be 100% to consider using it. You have contained defects which are less than 5 millimeters, AMIC with bone graft. You have contained defects which are more than 5 millimeters in depth, without bone graft for less than 5, with bone graft for more than 5. And your cystic defects, we've discussed structural autograft. Are there any questions at this point before we discuss one final case? In the audience, please feel free to post in the chat box. Amer, do you have, has that changed your practice to an extent, or are you still not sold?
Are you asking me whether I'm in the 21st century now?
No, I'm asking you if you're gonna consider changing your practice. And there is no right or wrong with this, as we all know.
To be honest, there isn't actually that much difference between what you've advocated and what I'm actually doing. So it's actually been quite reassuring for me that I'm not that far behind.
Fantastic. I knew you weren't.
And I think that your algorithm was excellent, because it's given a very sort of clear guide as to how you can approach these injuries.
Okay.
So
we've
got this.
Finish off with this case. Okay, we're pushing to you as a systematic review on OCDs. If you want to download for some bedtime reading, not that you've got enough papers now already. Amer, over to you.
Okay, so last case, medic who's 32 years old, who's got chronic ankle pain. Again, no clear history of trauma, but we know that that may not be reliable. No symptoms of instability. They've already had some treatment, a microfracture that was done a few years ago, and she's been offered further surgery, but it's not really clear what that surgery involved. Have we got another picture? Yeah. So this is one of those, oh, wow, type images where you think, why my clinic? So let's push the poll.
Yeah.
And the question is going to be, what is the surgical option? Now that you've heard Raheel's really informative talk, your brain is going to be whizzing. What kind of option are you going to offer this patient? So we've got the structural autograft, the structural allograft, AMIC, any, or fusion.
Okay, so just to reiterate to the audience, because I do think we have some young surgeons here as well, allograft is your last ditch effort, last option. As a surgeon, try to stay away from it as much as possible. Because you won't, even if it's easily available, the outcomes don't seem to be fantastic. Okay. Structural autograft is totally different. Yes, you can seriously consider structural autograft as an option. So this chap actually was offered surgery in Switzerland. He pitched up in my clinic fairly recently, and I discussed him in a foot and ankle forum, primarily to see which way do I approach this, because I knew what I wanted to do, but the question is, because that's quite a posterior defect, how do I approach this? Because I'm used to just going medial malleolar osteotomy or through a transfibular osteotomy. Amer, any thoughts? Let's see what the audience seems to suggest. AMIC with bone grafting and structural autograft seem to be the winners. There's a tie between the two. Both reasonably sensible procedures. We'll unpick one versus the other in a moment. Amer?
All right. Well,
surgical approach.
Surgical approach. I think this is a
tricky one.
Difficult one, but it's very, very central.
Because you've not seen this, these cases.
No. I think what I would actually do, I might actually be tempted to go to do a posterior malleolar osteotomy, because that would probably give me the best access. And my personal option would be to try to bone graft that and then use AMIC, because I feel comfortable using. I've used it a little bit, and I think that would be the best option in my hands. But as you said, sometimes there's no right answer, and every option has got its own risks. It's just a question of what the patient wants as well. But this is a young patient.
So I'll tell you what I did. Okay, I sat and scratched my head. I knew what I wanted to do, but I didn't know how to approach it. So I phoned a friend. Okay, I asked a fair few people, colleagues, wider foot and ankle group, about how to approach this. And believe it or not, I got 4 different answers. Some said approach it through a medial malleolar osteotomy. Some said approach it posteriorly. Some said go transligamentous. Some said go through a fibular osteotomy. So then I decided, you know what, no, whatever I do, it's not going to be wrong, because there is no absolute consensus on this. Now let's just look at the surgical options, and a lot of the audience has gone with structural autograft and AMIC with bone grafting. I think both of those are completely reasonable. Fusion is always an option, which I offered the patient. Okay. The problem, if you go back to this scan, and if you look at this, the roof seems to be intact. There's a bony roof, and the scan seems to suggest a roof. Now, if you have a roof, you've got to intraoperatively see that cartilage, and if it's non-viable, take it out, back it, and AMIC it. But if that cartilage is intact, you're going to waste cartilage which is there. I'm not saying that cartilage is 100% pristine, but it's better than anything we might be able to create. So that was my thought process, and I consented the patient for both. The other thing you've got to bear in mind when your decision-making process is occurring is what's happening with these large defects in the joint below. Now, at any point, if you have a breach in your subtalar joint, from the lower end of the talus, then packing it with bone graft is just going to cause bits of bone to trickle into the subtalar joint, and the patient's never going to be happy. So you've got to have a fairly contained defect with that floor not breached to consider your AMIC with bone grafting. So that's just a point to think about. Okay. So we discussed this. We decided AMIC with bone grafting. Sorry, let's just push this poll to the audience. This is the final poll.
It's pushed.
Okay. You decided on a posterior approach, and you wanted to do a posterior tibial plafond osteotomy, correct? And where will you hinge that? Will that just be a free fragment? You're going to hinge it on your PITFL, soft tissue hinge?
I'm going to try, I'll try to maintain the soft tissue attachments distally and pull it back.
Okay. So let's see what I did. I've got a brief video here, final video before we round up. 70% of the audience seems to go with medial malleolar osteotomy, which is a completely reasonable option. My concern with that was that if you go back to your, it's quite a lateral base. I wasn't sure how much of the tibial plafond I will have to bite into and osteotomize to get to that lateral edge. So I decided to go with a posterior osteotomy, a posterior approach, but I did not do an osteotomy. So this is the posterolateral box standard approach. As you can see, we have our sural nerve we've got to protect, or no matter what you do inside, the patient's never going to thank you. And that's the FHL and the perineals under the retractor, the nerve and the perineals, which we've retracted. And if you can notice for the keen-eyed ones there, I have put an external fixator across the ankle, spanning X-fix, a Hoffman, because I wanted to jack that joint.
You're clipped in properly there, Musab. You're not clipped in properly there. Release the tension. You tighten that.
Give me one moment. Let me just minimize the... Okay.
Tighten this. Then loosen these, and we can pull on this and...
Okay, so that's the defect. You can see it's staring at us. So I didn't actually need to do an osteotomy from the back. Interestingly, I released the X-fix and I was able to access it fairly easily. And there you can see it's being curetted out.
Fantastic.
Irradiating my hand. And then we drilled with multiple drill holes. And pretty much the same thing. We could essentially look right all the way up to the neck of the talus. So it was a large cyst. And once we'd done that, we packed it with plenty of iliac crest bone graft with stem cells, which we had harvested earlier. And finally,
the retractor is not doing anything. Take the retractor out of the way.
About the audience. So that was packed. And once we did that, I'll show you the final images. There was some extra stem cells which were left. We flushed into that cavity, and that was the final result. And the X-rays showed a reasonably well-filled graft. This patient is now 3.5 months down the line, fully weight-bearing and comfortable. I just got a call in my clinic today that the pin site, the proximal pin site from my X-fix, seems to be causing some irritation. I hope he's not developed an infection from that. But otherwise, from the ankle side of things, he's doing really well. So that's the final case we had for you today. Amer, do you have any thoughts? Would you do something different?
No, sorry, I've completely blacked out.
That's okay. We can still see
my
you.
light's gone out. Sorry. Right, so I think basically what you've done is quite amazing. That was a really fantastic result. Did you actually plan to do an osteotomy, or did you?
Okay, so I lie. I didn't do an osteotomy, but I did almost like a notch plasty. I took a couple of millimeters from the posterior lip of the tibia, but actually, in retrospect, I did not need to. If I had jacked out that with the X-fix, and I released the X-fix, and I found that I was able to access without the X-fix as well. So it was fairly easy to access without jacking it out. And in retrospect, I did not need to do that 2 millimeter notch plasty. I sutured the PITFL, a rent in the PITFL before I closed up, but that's the disadvantage of probably making the ankle unstable. Okay, so
Great.
Amer, do you
Well,
want to round
that
up
was
with some final thoughts?
Okay, so I think what we've seen today is we've had a look at a few cases and tried to look at the practical implications of looking at the imaging and working through an algorithm. And Raheel's given us an excellent talk to describe not just the pathology, but also go through the literature, and he's given us a really useful algorithm on which we can base decision making for the future. So I'll consider myself well and truly brought up to into the 21st century by Raheel.
You are in the 21st century. Any questions from the audience? Any? We'll give them a minute. So Amer, how often do we see these defects? We'll give them a few seconds if they've got any questions.
Well, quite clearly, you know, from what you've said, these are occurring a lot more frequently than we expect. You know, we often have patients who have ankle fractures who have niggling pains, and you know, quite often they'll have pain at the front of the ankle. And sometimes we put this down to, you know, soft tissue impingement, but perhaps we should be scoping a lot more of these patients in the future.
I think absolutely. We've got a question from Abhijit. Hi, Abhijit. Nice to see a friendly face from UK, one of our consultant colleagues. Do you ever use injectable bone graft? Amer, do you?
I don't. I don't really like it.
Just to qualify that statement, are you talking of hydroxyapatite-based things, or are you talking of subchondroplasty? Yeah, okay. So he is talking of hydroxyapatite-based applications. Do you use them, Amer? Because I know you do a lot of bone reconstructive work with large defects in the tibia.
I do, but I must say I'm not very keen on injectable bone graft because sometimes there can be problems with reabsorption and turnover of that particular bone graft, and it doesn't give you the same kind of structural robustness that you get with conventional bone graft. So I'm not very keen on it personally. Just a few times that I have used it, I haven't really felt that it's given me a good result. Okay. What about yourself? Are you a natural or a synthetic person?
No, I do a mixture of both depending on the size of the lesion. I open up the iliac crest quite generously a lot of the times and I take graft. Sometimes if I find that I've not taken out enough and I've sewed up the the pelvic region, I add graft. In answer to Abhijit's question, Abhijit, I've done subchondroplasty, and that's a completely different concept. I'm sure you quite a few of us are familiar with this, where when you have bone marrow edema syndrome, it's essentially subchondral stress fractures in that area. So there are commercially available companies which create subchondroplasty equipment. I have used it in a couple of patients. I found them to be extremely painful, and that's probably because I injected too much and created a lot of tight pressure in that subchondral space. Okay, so Lucy's just asked for a repost of the summary algorithm. Final. Okay, Lucy, let's just. What we'll do is we will actually get you. I'll tell you what. This is going to be. We'll post it. Email it out to yourself, and the recording will be on the website as well. So, how do you view post-op edema on MRI? Does it correlate with outcome? Okay, great question from Manal. Amer, post-op edema on MRI.
Well, the problem with post-op edema on MRI is that it persists for so long, and personally, I don't think it really helps you make any judgment on prognosis, because you'll carry on seeing that edema for up to a year afterwards.
Okay, I actually counsel my patients about this. This is a great question from Manal. Pre-op, I tell my patients it's all about tempering expectations. So I under promise, over deliver. I tell my patients that you are going to have changes on your MRI which might last you for years, and that's in no way a reflection of what we are doing. It's just the way it is, and it's not going to correlate with your outcomes. So I don't, Manal, in answer to your question, from an evidence-based perspective, I don't know or I didn't look into that when I was looking at coming up with this talk as to whether the edema on the MRI correlates with outcomes. But from attending meetings at the ICRS, I'm aware that actually it does not tend to correlate. But if you're asking me for some hard evidence, I don't have it off the top of my head. We can look into that. Okay, great question from Abhijit about post-op protocol for large uncontained defects. That was actually one of the questions in the poll. I'm not quite sure how we stopped before we asked that question for that last patient. Post-operatively, I get them non-weight bearing for 2 months. If they're sensible, I will start letting them gradually weight bear thereafter. I know people who keep them non-weight bearing for much longer, for 3 months, but we allow active range of movement exercises and passive range of movement exercises at 2 weeks post-op. Protected in a boot for at least 3 months, sometimes longer. Great. Amer, that was fun getting your reactions and learning a lot in the bargain as well. I hope our audience enjoyed it. I look forward to seeing you next week, Amer, where you're going to be discussing Lisfranc fractures. If people are interested, please do join us. We will be here same time next week. Thank you very much, Amer. And thank you to the audience.
Thank you, Raheel. I'll see you next week. Bye-bye.